we proceeded with the investigations. So blood routine showed hemoglobin of only 7.2 with total count of 6,300, distributed as 77% of neutrophils, 28% of lymphocytes, 3% eosinophils, 2% monocytes. Platelets was 1.26 lakhs. ESR was raised at 120 millimeters in first hour. Blood group O positive. Serology of hepatitis B, hepatitis C and HIV was non-reactive. Liver function test, serum bilirubin was 0.4. However, total protein was reduced to 4.9 with albumin of 1.4 and globulin of 3.6. The AG ratio was only 0.388. SGOT 36, SGPT was 28 with alkaline phosphatase of 245. The BTCT and P time and INR was all within normal limits. Lipid profile was also deranged. Triglyceride of 212 mg per deciliter, cholesterol 354, HDL 62, LDL 230 and VLDL 62. Workup for tuberculosis was not contributory. Sputum for AFP was negative and Mantoux test was also negative. Urine examination revealed an albumin of 3+ without any traces of sugar. There was no cast seen or any RBC. Urine culture did not show growth of any pathological organisms. 24-hour urine protein was 10.6 grams per 24 hours. Chest X-ray shows a blunt CT angle on both sides with raised homogeneous opacity more on the right lower regions. USG was done, which showed features of bilateral pleural effusion with kidney size of 9.7 into 4.05 in the right side and 9.8 into 4.4 in the left side. The corticomedullary differentiation was normal. CT of abdomen was also done, which showed features of ascites with minimal pleural effusion on the right side with hepatomegaly. ECG had normal sinus rhythm without any STT changes. Echo was also done, which showed a normal left ventricular size with thickened interventricular septum with good LV function. Valve shows trivial MR with AR. There was no regional wall motion abnormality. Pericardium was normal with left ventricular ejection fraction of 73%. Now pancreatic tissue disorders was suspected and workup was done, which showed ANA positive, RA factor negative, anti-DS DNA positive at 27.1. So now with altered AG.
So it's the case of SLE nephropathy. Only the odd thing is the age of the patient. Generally, SLE is a disease during the menstrual period of a woman. But after this, SLE incidence is gradually decreasing. So, any opinion from our learned colleagues that why SLE first appeared as in the age of 65 and no other symptom, photosensitivity, joint pain,
No rash.
no rash.
No, nothing.
Or anything else.
SLE plus.
SLE plus anything else we are related.
Sir,
I think
Yes,
if you look at the recent classification of redefining lupus and late onset lupus, it's not that lupus is always of the younger age, it may be late onset also low, what is called low something like I can't remember. And recent classification, just renal presentation with ANA and PTSD maybe a SLE. So I think it's very unusual presentation, but it can be a possibility. Another thing I was thinking, whenever an elderly lady with anemia, renal failure, one should think of amyloid, right? There was some scar X-ray also. That I rather forget to mention, because always has to be in our index of such.
We have to evaluate because
Thank you, sir. So there was anemia with altered AG ratio, which was losing protein, and we had done an X-ray skull, which did show a couple of lytic lesions, and subsequently urine for benzoin protein was also sent, but it was negative. Then we did a bone marrow, which showed 5% of plasma cells, and the SPEP was done, which clearly showed M band. So at this point, it was with anti-DSDNA positive and was going towards multiple myeloma. Concentration of the hematologist was taken, and patient was started with bortezomib. And subsequently, renal biopsy was also done, and biopsy report came, which showed 12 glomeruli showing pale eosinophilic pus positive material in the mesangium and basement membrane, showing apple green birefringence. The tubules had acellular amyloid material with 25 to 30% of atrophic tubules. The vessels showed amyloid deposit in the walls of interlobal arterioles. Immunofluorescence showed 2 viable glomeruli negative for IgA, IgM, C3 and C1 deposits. Lambda kappa chain stains were also negative. Congo red shows positive for amyloid. So the diagnosis came as AL type of amyloidosis. This was the slide. And final case, it was a case of renal amyloidosis leading to nephrotic syndrome due to multiple myeloma in a background of hypertension with hypothyroidism. The anti-DSDNA can be positive in case of multiple myeloma as per the
Both DSDNA and ANA, both positive.
both were positive.
Which process, SIP or what was the title?
Sir, 26, this is the borderline. Actually, that means one is out of 55. 56, 27. Because of that.
ANA and DSDNA. Positive which method?
F2 cells was not, we don't have F2 cells.
As far as I know little about SLE, I am not an expert on SLE like you. One thing that was in one impression that I always had, that anti-DSDNA positive is specific for SLE. That is the impression that I have.
I'm coming to it. The most what I'm doing in rheumatology after so many years, I think if you want to do ANA and DSDNA, must be in a standardized method and must be the latest recommendation. ANA by Hep2 cell method and DNA by SHIP method.
No, this is not we are doing, sir. Elisa method we have done it.
No, let me finish. If in a the DSDNA is positive in a SHIP method in 1:10 dilution, then only one disease in this world, that is SLE. Otherwise, you may be confused like this. If you, in a meeting you say that ANA and DSDNA positive, so everybody will have an impression that we are dealing with a case of SLE. But there are hundreds of methods, ELISA, and these are false positive. So if you think that it may be false positive, so I think that a institution may not provide the latest methods, but from outside you must exclude or include the diagnosis of SLE. Multiple myeloma presenting with primary amyloidosis, this is a very known fact, and in API meeting lots of cases have been produced that nephrotic syndrome in a case of multiple myeloma with primary amyloidosis. But the most interesting part is that when somebody level that ANA and DSDNA positive, everybody will have mind that is a case of SLE. But last of all, we came to know that ANA and DSDNA was done in some ELISA method, not the.
In our hospital, it is been done by the ELISA method.
I agree to you. In our medical college, where I was posted, not ANA and not DSDNA in any method was done till today. So this is the deficiency of a government institution. We can't help it. So we'll have to take the advantage of latest available in the market to include or to exclude a case of SLE.
Two, 3 points are here in our patient, particularly the after multiple myeloma in bone marrow, it was myeloma cell is 5% showing only. That is also we are not very much convinced
So
for
you
this.
see, yeah, in a multiple myeloma there is a creep classification.
Yes.
Yes, triad will be there.
Creep classification. So previous criteria have been omitted, and the creep classification on 5% may be if you have a hyperchromatic nucleus, and if the other features of creep are you satisfy. So you have satisfied the other features of the creep classification, and no doubt it is a case of multiple myeloma with amyloidosis because you have shown the positive apple green bisphagis.
Yes.
But the most confusing part is the ANA. So I request everybody that if you suspect SLE in a patient, the only thing when I write ANA, in other investigation I told patient you go to any laboratory. But when I write ANA, I write Hep2 cell method and from right. Because otherwise this confusion
Will arise here, definitely.
And one clinical clue, Dr. Banerjee have mentioned initially, that was a dystrophy of nail. That is a particularly for amyloidosis. Raccoon sign and dystrophy nail
My
were the
suggestion is,
basically.
if you find ANA in ELISA method, okay. But to label it, to exclude it as SLE or include it as SLE, you must do ANA in the Hep2 cell method and dsDNA by clip method, so that either SLE or not SLE. Otherwise, this confusion will definitely occur.
Can it be coexistence?
No, you
Acha, that I am to search in net.
coexist?
If there is a coexistence of SLE in multiple myeloma, I don't know.
We have gone across 2 studies.
Uh,
There are cases where autoimmune hepatitis,
What is very
Leading to this.
no, that has a positive dsDNA. Apart from
I agree, but not in a say clip method in 1:10. Yes, autoimmune hepatitis definitely, but your liver enzymes are not increased. So it is not a case of autoimmune hepatitis, I think.
No.
But any opinion about this confusing SLE?
I think that is the lesson